Right, today we are going to talk about the management of the trigeminal neuralgia. Basically there is medical management of trigeminal neuralgia, that is managing with the drugs. And if drugs don't provide sufficient relief or drugs cannot be tolerated due to their side effects, then we go for the surgical management, right? So first of all, in this part of lecture I will go in detail of medical management of the trigeminal neuralgia. So we will talk about the drugs. Now the drugs which is used in trigeminal neuralgia, the first line drug, the gold standard drug is carbamazepine. That is carbamazepine. This is the gold standard drug. And then as I will move on in the lecture, I will talk about what is the important difference in carbamazepine and oxcarbazepine. Zapine, which is also another important drug which can be used in trigeminal neuralgia. Now first of all, carbamazepine, how does it work? The most of the drugs which are used in medical management of trigeminal neuralgia, they are basically anticonvulsants, right? Especially carbamazepine, oxcarbazepine, and later on I will tell you we also use drug phenytoin sodium or lamotrigine. Now these four drugs, carbamazepine, oxcarbazepine, and phenytoin, sodium and lamotrigine, primarily they are anticonvulsant drugs, but they are also effective in trigeminal neuralgia. So first of all I will mention how these drugs work. How carbamazepine reduces or even eliminates the pain of trigeminal neuralgia, right? As we discussed previously, the trigeminal neuralgia, the classical type of trigeminal neuralgia, I'm talking about the classical type of trigeminal neuralgia, the main cause of classical type of trigeminal neuralgia was that there was an anomalous vessel, right, which was compressing the trigeminal nerve root, right? Let me draw it here just for a reminder that what really happens. Here is your midbrain and pons and medulla, and here was your trigeminal nerve, sensory root, right? And here is your trigeminal ganglion with your deviance, right? We already discussed all this, and what I have discussed in previous, that most common cause of trigeminal neuralgia is that there is either a artery or an anomalous vein which is compressing on the trigeminal sensory nerve root, and that may produce the classical symptoms of trigeminal neuralgia, right? And as we discussed previously, what really happens, that this artery was, or compression was, leading to demyelination of nerve fibers, right, especially fast conducting tactile fibers, and those demyelinated nerve fibers become coupled with less myelinated pain fibers, and those demyelinated fibers have a tendency to produce spontaneously excessive action potential. What was the underlying cause? I will explain how the underlying cause is managed by these drugs. So we just do a little rewind, that this artery or this compressive lesion, this is leading to demyelination of heavily myelinated fibers here, which are proprioceptive fibers and touch fibers, and these demyelinated fibers, right, at the site of the lesion, they become coupled with less or least or non-myelinated pain fibers, and these demyelinated fibers are hyper excitable, right? These demyelinated fibers are hyper excitable, and they sometimes spontaneously produce excessive action potential, or by a special trigger in the face they produce excessive action potential, and those excessive action potential coupled with the pain fibers, they produce intense episodes of excruciating pain in the area of distribution of one or more of the trigeminal deviation on the face. Now, if I say that carbamazepine is the gold standard drug, right? If I say it's one of the most effective drug, if I say this is the first line drug, then it means that somehow carbamazepine must be reducing the production of excessive action potential here, right? It means that then carbamazepine or oxcarbazepine or phenytoin or lamotrigine, somehow these drugs must be reducing the excessive generation of action potentials, pathological generation of action potential in this area, right? How really they do this work. For this, I will explain that major function of these drugs is, how do they act? What is the mode of action? Major mechanism is that these drugs are basically sodium channel blocker. They block the voltage gated sodium channel. Again, we go into little more detail. Let's suppose I remove a neuron from here, right? Axon. And here is that axon. Okay. Here is that axon. And there are, in this axon, there must be sodium channels. Voltage gated sodium channel or voltage sensitive sodium channel. So let me draw a sodium channel here. This is a sodium channel, and actually there are millions of sodium channels here. If this nerve is not stimulated, then sodium channel is in inactive state, or no, if it is not stimulated, then it is in resting state. Let me draw one sodium channel largely here in the resting state, right? Here is the sodium channel, and here is your neuronal membrane, right? This is inside and this is outside. I mean inside and outside. Now how the sodium channel operates? Normally sodium channels have, when they are resting, when this nerve is not stimulated, sodium channel has two special gates. One is, yes, this gate, which is called activation gate, and this gate is closing the sodium channel. It does not allow the sodium to go in. And other gate is inside, and this is called inactivation gate. This is called activation gate, activation gate of sodium channel, and here it is inactivation gate of sodium channel. Now, in an inactive neuronal membrane, which is no more stimulated, most of the sodium channels are in this phase, right? But when appropriate stimulus come, a resting membrane potential, which is here at 90 millivolt, right? It approaches the threshold, right? For example, from minus 90 millivolt, when appropriate stimulus is coming or a volley of action potential is coming, if resting membrane potential go to threshold, as I told you, these channels are voltage sensitive. They can sense the change in voltage. So when it is slightly, what is happening? Stimulated, resting membrane potential goes to threshold potential. Let's suppose threshold potential is minus 60 millivolt. Right? And in resting membrane potential, sodium channel was, activation gate was closed and inactivation gate was open. Right? And as soon as it went to threshold, what really happens, that these gates change their behavior. How do they change their behavior? Now sodium channel into next phase. It was resting phase. As soon as it is appropriately stimulated, here when it was not stimulated, it was minus 90 millivolt. When it is at threshold of stimulation, suppose it's minus 60 millivolt. What really happens? At this very moment, activation gate starts opening. Because it was voltage sensitive, it starts opening. It's lifted up. And inactivation gate start closing. Again, when it is appropriately stimulated, activation gate start opening and inactivation gate start closing. But for a very brief moment, for a millisecond, very brief moment, it is not yet opened completely and it has not yet closed completely. This is the moment when extracellular sodium start coming in. Is that right? This is when sodium influx occurs. Is that right? And sodium will come in, and this electronegativity minus 60 millivolt, right? That will be neutralized because more and more positive charges are coming in. Let's suppose now this channel activation gate is opening. It means activation gate is activated and inactivating gate is closing. During this time, sodium influx is coming. This is called active stage of the channel. What is the stage? Active stage of the channel. Now we say that sodium channel is activated. Here it was resting phase. Sodium channel was taking rest, and then the channel, and now it is activated and sodium come in. When enough sodium come in, then resting this minus 60 millivolt, more and more sodium come in. It's a positive charges moving in. What really happens that it becomes 0 or plus 10. It means negative polarity is lost. We say membrane is depolarized. When membrane is depolarized, you know what happens? These gates are also sensitive to depolarization. They sense the change in membrane potential. And then they say, okay, we have depolarized the membrane. Enough sodium has gone in, and membrane has become depolarized. It has lost its negative polarity. Then this channel will completely, this activation gate is the next stage. Yes. Now activation gate, previously it was closed, then it started opening during the activation stage, and now it is completely opened, but this is completely closed. And again, sodium cannot go in, right? Now again sodium cannot go in. But remember, when channel was resting, sodium could not move in. And when channel is activated, sodium could go in. And when it is inactivated, sodium still cannot go in. Now, you see this phase and that phase is different, right? Due to that reason, this is called resting, this is called active state, and this is called inactive state. What is it? Inactive state. Is that clear? Now a very important piece of information. When sodium channel is in this phase, it cannot be stimulated. Even you bring any stimulus to the neuron, it will not open up and not let the sodium go in. Before it becomes re-excitable, before it becomes re-functional, it is required that this channel should flip to this state. It means to be stimulated, this channel has to open inactivation gate and close activation gate. Is that right? It means when channel is in this state, it is not working and it is not excitable. But here channel is also not working, but it is excitable. So this is resting phase, this is active phase, this is inactive state, this is inactive state of sodium channel. And when it is inactive, it is refractory. It is refractory to the stimulus. You stimulate, but it won't work. Yes. Before it becomes again excitable, I would love to repeat it. Before it becomes really again re-excitable, it must flip back to this state. Is that right? Now, this is the basic function. Now what really happens? When this nerve is stimulating and it is hyper-excitable, and it produces excessive action potentials, it means sodium channels are rapidly flipping from this stage to this stage to that stage, and again going back to this stage and repeatedly. It means sodium channels are, when rapid excessive action potentials are being produced, yes. It means most of the sodium channels are in excitable stage. Yes. And when they are excited, they rapidly go into activated state, yes. Then they shift to inactive state, and important thing is they rapidly recover into resting phase. And they repeat the cycle, and action potential keep on generating. Clear? Yes. Now, how our drugs work, how carbamazepine work, how oxcarbazepine work, how phenytoin sodium work, how lamotrigine work. All of these drugs have one thing common in their action. They are sodium channel blockers. They block the sodium channels. They plug the sodium channels. Is that right? How do they plug? These drugs can only block the those sodium channels which are superactive. Because if sodium channel remain into this stage, drug cannot enter in. Drug cannot enter in. Let's suppose this is the drug. What is the name of this drug? Carbamazepine. Right? And other three drugs also have similar mechanism of action. Now, this carbamazepine here, can it enter into the channel? No. But as soon as it open the mouth, as soon as it open its mouth and channel become activated, this will also jump in. It enters into channel. Either it enters from outside or it goes through the membrane and enters from inside. But the important point is, it will only plug the what? Those channels which are talking too much. If channel refuse to talk, if someone refuses to talk, can you plug his mouth? No. But if someone is talking and again opening his mouth, you can plug in. And if someone is shouting, you can more chances to plug in. Yes. Is that right? These neurons are overfiring. So it means there are too much shouting. They are too much opening their mouths. It means there are too big chance this drug will stick in their mouth, plug in. So this drug enters here, and now this drug is happily stuck over here, right? And what it does, it produces a hook here and hold this channel into this state and push this to that side. Now drug has stabilized the channel into inactive state. You understand it?
Yes.
Drug has stabilized the channel into inactive state. Drug has arrested the channel into inactive state. Now it's a miserable channel. It cannot flip back into this in the presence of this drug. It cannot flip back into re-excitable state until drug is not dissociated. Until drug is sitting there, it is stabilizing the channel into inactive configuration. Is that right? Now, after you understand how these drugs work, right, especially carbamazepine, oxcarbazepine, phenytoin and lamotrigine and some other, these sodium channel blockers, now you will tell me one thing. For example, these are 5 neurons, these are also 5 neurons. These neurons are firing at regular speed. These neurons are overfiring. It means these neurons, sodium channels are less activated. These are overactivated.
Yes.
Right? These neurons are using their sodium channel less. These hyperexcitable neurons, like epilepsy neurons or like neuralgia neurons, they are using their sodium channels less or more? More. So if you give the drug to this person, it will stick into these neurons more or these neurons more? These neurons more. So we say these drugs have their action use dependent. More a neuron uses its sodium channel, more the sodium channel gets stuck. We say this drug has sodium channel blocking action which is use dependent sodium channel. It's the beauty of this mechanism of action. You know why? Because then these drugs will block those neurons more which are pathologically overfiring, and they will block less which are physiologically firing normally. Because when this drug go associate with the channel, after some time it dissociate. The channels, neurons which are using their sodium channels less, drug has less chance to plug in and has enough time to dissociate. Is that right? But in those neurons here, demyelinated hyperexcitable neurons which have a tendency to produce pathologically high frequency of action potential with little trigger in this disease, or by simple rub, when you give this carbamazepine, now this is very important thing to listen with your both ears. When carbamazepine is given in these patients in appropriate doses, eventually this carbamazepine molecules will arrest or stabilize most of the sodium channels into which state? Inactive state, which is not excitable. So you don't remove the blood vessel keep on rubbing, right? But neurons become refractory and they cannot overfire, and symptoms, excruciating paroxysms of excruciating pain disappear. That's how this drug works. Am I clear? Okay. Now, how these drugs should be given? Very simple. Carbamazepine, start with the low dose. Let's suppose here I make a graph that here is the daily dose per day, and here I put time. Start with the low dose and gradually build it up, right? And then stabilize at appropriate dose. And when you have to stop the drug later on, when you suspect that patient disease has gone into remission, you have to reduce the drug or stop it, very gradually reduce the drug, right? I will tell you why all these things need to be done and how. Actually, this drug you start with a dose of 100 milligram daily. Start with low dose and gradually increase the dose until significant response is achieved. We say pain should be at least reduced 50% of it, and some lucky patient pain disappear. Now, most of the patient when you build the dose, they are stabilized at, you can say, about 800 milligram per day into 3 divided doses or 4 divided doses. It means 200 milligram every 6 hourly. Is that right? So about most of the patients are stabilized here. But if pain is not getting better, you can increase the dose and take to 1200 milligram per day into divided doses. Is that right? Into 3 or 4 divided doses. Am I clear?
Yes.
Most of the patient, about 70% patient, get pain relief. Is that right? But here's the very important thing. If some patient don't get relief up to 1200 milligram per day doses, don't increase the dose further, because then side effects will start appearing. Maybe that is the time to change the drug. That is the time to change the drug. We will go to some other drug. Is that right? Again, carbamazepine is a sodium channel blocker, right? Similarly, oxcarbazepine, phenytoin sodium and lamotrigine, they have other actions also, but major action is they arrest the sodium channel into inactive state and reduce the hyperexcitability of the neurons. In this way, they reduce or abolish the symptoms of trigeminal neuralgia. Done? Start this drug with slow dose, gradually build up the dose until patient get relief. But most of the patients are stabilized 800 milligrams per day into 3 divided doses or 4 divided doses. But in some patients, you need to take the dose upward up to 1200 milligram per day. But more than that is usually producing side effects. So it's better than to switch the drug.
Yes.
Am I clear?
Yes.
Another thing. Why we gradually build it up? The reason being that if you rapidly build it up, side effects will come. Is that right? And this drug, carbamazepine, induces its own metabolism. More you give it to the patient, more rapidly patient will start metabolizing the drug. So when you start the dose, patient is not metabolizing the drug that fast. But as you gradually increase the dose, why we need to increase? Because liver microsomal enzyme system start destroying the drug or metabolizing the drug at faster pace. So we increase the dose. Then how long it should continue? If appropriate response is achieved, if significant relief is achieved, usually 1 month to 2 months, because the attacks of trigeminal neuralgia, as I told you, they come as a single jab or they may come as clusters, and these clusters, repeated attacks, sometimes hundreds of attacks per day in some unfortunate patients. So these attacks usually they remain for a few days or few weeks or 1 or 2 months, and then in majority of patients they go into spontaneous remission. So we start the drug and we wait for the remission, and when you think that after 1 month or after 6 weeks or 8 weeks, you gradually start tapering off the dose. start reducing the dose, right? And if dose is being reduced, don't reduce it too fast, very gradually. You know why? Because if you reduce the dose abruptly, maybe the system bounces back and recurrence of the disease occurs. Am I clear? This is one thing. What are the important side effects? Very easy to understand important side effect, because it is sodium channel blocker. So naturally it basically suppresses certain action potential systems in our central nervous system. Now, as it is use dependent blocker, so it means those neurons in our central nervous system which produce more action potentials, they will get this drug more into their mouths of sodium channel, and they will be the more sufferer. So cerebellum, vestibular system, vestibulo-ocular pathways, and cerebral cortex, these are the major target of this drug to produce the side effect, right? So what happens? For example, when cerebellum has side effects, right? Unwanted action of the drug, right? What happens if cerebellum or vestibular system is damaged or inhibited by this drug? That will produce ataxia. What does mean ataxia? There's no taxi around? No, ataxia means incoordination of the movements, right? Cerebellum and vestibular system is related with coordination of the movement. Secondly, nystagmus. Nystagmus is that there is oscillatory movement in the eyes. Eyeballs are unable to maintain their balance. And then there may be even diplopia, double VN, because both eyes are out of visual axis. Normally the visual axis of the both eyes should be parallel. So double VN patient may complain of ataxia, incoordinated movement, or there may be double VN, or you may notice, doctor will notice nystagmus, oscillatory movement in the eyes. Is that right? Yes. With that, patient, yes, when cerebral cortex is inhibited, when vestibular system is also vestibular nuclei, which are rapidly firing nuclei, their connections are inhibited, patient also may get dizziness or vertigo. Dizziness or vertigo, right? Then if cerebral cortex is slightly inhibited, or radicular formation and cerebral cortex is inhibited, that will lead to sedation, right? Confusion, impaired concentration. So these drugs are really not very wonderful drug. You have to build the dose very carefully and don't take it to the toxic range, right? But one side effect which is rare but which may kill the patient, every doctor should know. That is bone marrow toxicity. Carbamazepine can produce bone marrow failure. And if bone marrow house, here is your bone marrow house. If bone marrow house fails, what will happen? You know, bone marrow normally produces RBCs, yes, white blood cells and platelets, right? If carbamazepine start damaging the bone marrow, what will happen in the blood? Right? Blood, these cells number will start going down. And out of these drugs, these cells, granulocytes, especially neutrophil, they have very short half-life. They survive only 1 to 2 days. RBCs survive for 120 days. So when bone marrow start failing, RBC number does not rapidly go down in blood because RBCs have long life. But when bone marrow fail to produce the blood cells, as neutrophils survive in circulation in 1 or 2 days, few days, so their number rapidly go down, and neutrophils are granulocyte. So we say these patients may get agranulocytosis or neutropenia, and that will be clinically manifested by repeated infections. Patient is on carbamazepine. If patient's bone marrow is failing, patient will start getting repeated infections due to failure of granulocyte system, and if platelet number also go down, patient will start getting petechiae and other skin problems. Now, what does it mean? It means when you start this drug in a patient, you have to do serial blood test. Repeatedly check the patient blood while the patient is on carbamazepine. Their bone marrow is working well, and are the blood counts maintained in healthy range or not? If there is the slightest hint, then blood cells, especially neutrophil number, is going down, you need to stop the drug immediately. Am I clear?
Yes.
So most dangerous side effect, even though rare, common side effects are ataxia, diplopia, nystagmus, dizziness, drowsiness, sedation. But most dangerous side effect, thank God it is rare, that is agranulocytosis due to bone marrow failure. Clear?
Yes.
But here come another drug, which is a lovely drug. Oxcarbazepine. We are very happy with this drug. You know why? This works in the same fashion as carbamazepine. It's a newer drug. It works in the same fashion as carbamazepine. They also think it's almost, its efficacy is also same as carbamazepine. The only beauty in this is it is less bone marrow toxic. Most dangerous side effect was carbamazepine. What was the most dangerous side effect? Bone marrow failure. Bone marrow suppression. Agranulocytosis. And the beauty of oxcarbazepine is that it gives all the benefits which carbamazepine give, but it has reduced chance to produce the bone marrow toxicity. Is that right? That's the beauty of this drug. So we can say in first line drugs, right, either you use carbamazepine, that is gold standard because from many decades it's being used. It's a newer drug, but still we are considering it very seriously because of less bone marrow toxicity. Am I clear?
Yes.
Any question up to this?
Can we give any medicine for pain management?
Okay, so you are, he has a very good question. He is saying, can we give some non-steroidal anti-inflammatory drug for this pain, neuropathic pain? Answer is that no. This pain does not respond to aspirin or Disprin or paracetamol or you can say Brufen, right? This is very, very nasty pain. That is why we don't use common analgesics in this case. We go very special analgesics like carbamazepine. These are not really analgesics. These are anticonvulsant drugs, right? Anti-epileptic drugs. We use these drugs which reduce the chances of production of high frequency firing in trigeminal root. Am I clear? Okay. So then there are other drugs. Let's suppose if carbamazepine or oxcarbazepine, if these drugs, any one of these drugs, you don't give them two drugs, either use carbamazepine or give oxcarbazepine. If these drugs either don't give enough response, patient does not get relief, right? Or patient does not tolerate the drugs, side effects start coming. Then stop those drugs and go to the second line drugs in which we can use phenytoin sodium or lamotrigine, right? And then there are some other drugs which are also used. You must be knowing that in central nervous system there is another inhibitory neurotransmitter that is called Gaba. That is Gaba. Gaba stands for gamma aminobutyric acid. Gaba stands for gamma aminobutyric acid. It's a neurochemical in the central nervous system. It's a neurotransmitter which is basically an inhibitor. If somehow we can increase the GABAergic activity, it means we can inhibit the central nervous system. And if we increase the GABAergic activity here, we can reduce the chances of excruciating paroxysms of pain in patient with trigeminal neuralgia. So another group of drugs which we use, right, in what is this trigeminal neuralgia management, if first line drugs fail all, right, then we go use the drugs which enhance the GABAergic activity, right? Here I will mention two drugs. Number one is Baclofen. Baclofen is, okay, again we can say this is a neuron and here is GABA receptor, right? GABA receptors, I will not go into detail of type of GABA receptors. We will have separate lectures on that. But, and let's suppose this is our drug Gaba. This is Gaba, right? Not drug. This is basically central neurotransmitter which is normally GABA bind with the receptor, and this receptor is either coupled with chloride channels or with the G protein, and eventually it leads to inhibition of neurons. There are two mechanisms. Either it pushes a lot of chloride in the neuron, chloride are negatively charged, right? Let's suppose if this receptor is coupled with chloride channel, when GABA bind here, lot of chloride go in and membranes become hyper negative, hyper polarized, and inhibited. Or some of the GABA channels, they are coupled with G proteins. They are coupled with G proteins inside, G inhibitory, and they with multiple pathway open the potassium channel and potassium goes out. And if potassium goes out, cell loses the positive charges and again become more electronegative. So GABAergic system inhibit the neurotransmission and inhibit the action potential and neurotransmission. How? By making the membrane more negative, so they cannot be excited. And how do they make the membranes more negative? Some of the GABAergic receptors, right, they are coupled with chloride channels and they push in more chloride inside and membrane become negative, or they are coupled with G protein system, which is finally coupled with the potassium channel and let the positive channels, positive ions go out. Either put the negative ions like chloride in or get the positive ions out and make it inhibited. So such drugs can also be tried after you have exhausted these drugs and they fail to give enough benefit or they cannot be tolerated. Then we use the drugs which are related with GABAergic system, right? Yes. Am I clear? Now, when we talk about GABAergic system, there are two drugs which we use. One is Baclofen, right? And other is Gabapentin. Gabapentin. Both of them work on the GABAergic system. Baclofen actually stimulate. Yes, this is what it is. Baclofen basically stimulate what? GABA receptors. Baclofen is a drug when we give it, right, especially in spinal cord and some other part of the central nervous system, it will stimulate GABAergic receptor and inhibit the neurons, right? And commonly it is used as central antispasmodic drug. Central antispasmodic drugs, right? So they are also effective in trigeminal neuralgia and they can be given alone or in combination with one of the anticonvulsant drugs, right? Then Gabapentin. Gabapentin is just like you can imagine. Gabapentin is a drug which is actually GABA with the pants on. GABA with the pants on. Gabapentin. What do I mean? That actually Gabapentin is actually analog of GABA. This is GABA and it is slightly modified GABA. So we can say this drug is basically Gabapentin is a drug which is analog of GABA. Its molecule is similar to GABA and it also acts like GABAergic activity and inhibit the hyperexcitable system, right? So this is the basic management of, what is this? Medical management of or pharmacologic management of trigeminal neuralgia. One thing I think it's worth mentioning, this Gabapentin, GABA with the pants on, yes, it is very effective in those patients of trigeminal neuralgia which are having symptoms due to multiple sclerosis. Right? Now let's have a break and then after that we discuss the surgical management of the trigeminal neuralgia. Of course we go for the surgical management when pharmacological management is either not producing significant relief or pharmacological management with relief producing a lot of side effects and intolerable side effects. Then we think of surgical modalities, right? That we'll talk after the break.